Good afternoon. My name is Shelley Dugas-Thomas, and I chose the topic of Black maternal health because it consistently emerges as a significant and urgent public health issue. It has also been a reoccurring theme in my previous PhD courses, including U.S. public policy and vulnerable populations, where the discussions highlighted persistent disparities, structural barriers, and the ongoing national concern surrounding maternal morbidity and mortality among Black women. So during this presentation, I hope to examine a critical health issue of Black maternal mortality by first defining the problem and its significance, then exploring the web of causation, recognizing that complex health disparities arise from interrelated social, economic, and structural factors. And to guide an effective intervention, the presentation introduces two theoretical and conceptual models. I will reside with one of those. And finally, the presentation concludes with some policy recommendations based on existing policies. So the United States has the highest maternal mortality rate among high-income countries, and the rates continue to rise. Black women experience 55.3 deaths per 100,000 births, and they are at least 3 times more likely to die as a result of pregnancy-related causes compared to white women. These differences persist even when controlling for age, education level, and socioeconomic status. Systematic inequalities in the schools, neighborhoods, and health systems that Black women have access to create an elevated risk for Black pregnant women. Black women experience discrimination based on race, ethnicity, class, and gender, which negatively impacts their health outcomes and well-being. Particularly, racism and racialization creates barriers that can be experienced on the micro, macro, and meso levels of care. For instance, Black women experience higher rates of pre-existing or pregnancy-related cardiovascular conditions that require awareness, appropriate monitoring, and adequate treatment by healthcare professionals. Exposure to chronic stress and the effects of weathering due to racism, discrimination, and denial of authentic self also contribute to a decreased sense of self, diminished self-care, and reduced security, all of which negatively impact Black maternal health. As a result of increased allostatic load, Black women also experience higher rates of preterm birth, low birth weight, and elevated maternal mortality. When examining the etiology of current Black maternal mortality rates, one must include the impact of marginalizing and discriminatory policies and practices such as enslavement, Jim Crow, redlining, and segregation, which legislated inaccessibility to healthcare systems, education, and resources. These practices continue to echo through Black communities and impede access to health promoting resources and opportunities. In particular, physical segregation has relegated many Black families into under-resourced and unsafe communities, which increase stress, comorbidities, and the risk for maternal complications. Lack of trust by the Black community toward the healthcare professionals is embedded in historical relationships, such as the Tuskegee syphilis trial highlights a history of exploitation by the medical profession that continues to influence how the Black community interacts with members of the healthcare profession, further fracturing the healthcare relationship between Black community is the case of Henrietta Lacks, whose tumor cells were taken without her consent or knowledge and later used in numerous scientific breakthroughs. So decisions made through political systems, through citizens, leaders, and policymakers determine how goods, rights, and liberties are distributed and how power is exercised. Without access to power, individuals are deprived of the resources essential for safety and health. The underrepresentation of Black women in healthcare leadership, policymaking, and research limits the healthcare system's ability to provide care that is responsive to their needs. Healthcare structures often prioritize provider authority and either implicitly or explicitly reinforce racialized hierarchies in which Black women autonomy and agency are undervalued or ignored. Specifically, providers may control the flow of information to exert power over Black women, leaving them without a sense of power when negotiating their care. Black women are often socialized to value resilience and adapt to life's challenges. While this belief can be a buffer against stress, it can also create barriers to optimum health. For instance, Black women rely on faith based coping, community support, and advocacy to navigate health challenges. However, some structural cultural patterns may inhibit them from expressing vulnerability or seeking timely healthcare intervention. Women in general are often socialized to prioritize the care of others over themselves, which can further exacerbate health challenges. Chronic exposure to psychological and environmental stressors can contribute to coping behaviors that negatively impact health, such as emotional eating, smoking, reduced activity, and both physical and emotional exhaustion. Mistrust and communication breakdown negatively affect relationships between healthcare professionals and Black pregnant women, contributing to higher rates of maternal morbidity and mortality. Implicit and explicit provider biases often result in the minimization or dismissal of Black women's symptoms, leading to misdiagnosis of conditions such as preeclampsia and other complications. Research further indicates that healthcare providers frequently overlook or disregard Black women's concerns during both prenatal and intrapartum care. Consequently, many Black women experience significant psychological strain and stress associated and due to the fear and uncertainty associated with placing trust in healthcare providers. So now we're going to look at some of the models. So first, the community-based collaboration action research is a cyclical process composed of 6 interconnected steps. Establishing partnerships, which includes stakeholders, change makers, researchers, individuals directly impacting the issue, and this includes gathering and listening tentatively to one another. 2 includes engaging in dialogue and moving forward slowly to remain alert to one another and the connectedness of ideas, and suspending judgment and becoming more cohesive. 3 includes recognizing patterns in which the group researches deeply to identify authentic, collective, and contextual understandings of human realities. 4 includes interpreting the meaning of those patterns by creating ways to transfuse data meaning and stimulate aha moments, and choosing the best medium, including community forums, dramatic performances, dialogue groups, artwork, songs, TikToks, or even short movies. 5 is generating insights that lead to action. The goal here is to change systems that create the conditions impeding people's health and well-being. Multi-level approaches are usually more effective in addressing structural issues versus one intervention targeting only critical reference group. And 6 is reflecting on evolving patterns through the process, which includes participatory and empowerment evaluation, and that is multi-level and holistic, in order to evaluate both structural impact as well as individual and group attitudes, knowledge, and behaviors. So the 10 guiding principles in this process include mutuality, which emphasizes the creation of equitable partnerships where all participants benefit from engagement. Equity serves as a driving force, ensuring that fairness and justice shape both the process and relationships. Context underscores the importance of situating data within broader historical, economic, and political realities. Inclusivity encourages openness to stakeholders, particularly those from marginalized communities. Patterns highlight how data can deepen understandings of intersectionality and influence. Meanings emerge and evolve within relationships and over time through intentional reflection, and representations invite creative dialogue and collaborative problem solving. Actions become transformative as solidarity and shared commitment to change take form. Finally, impact emphasizes the importance of evaluation as a necessary component. So, emancipatory nursing praxis is a middle range nursing theory that supports nurses in developing and applying critical awareness of the social, structural, and processes that systematically disempower certain individuals and groups with the goal of transforming these systems to promote health equity. Central to the emancipatory nurse practice model is the quantum spiral, which illustrates four essential and iterative components: becoming, awakening, engaging, and transforming, and also two contextual necessities, including relationality and also reflexivity. So, when deciding between the two, CB is built on a co-design with community members, and it also positions Black women, families, and community health workers and local organizations as equal partners in every step: problem identification, intervention, design, implementation, and evaluation, and also prioritizes cultural context, lived experience, and historical realities that shape Black maternal health. ENP aims to recognize and address oppression, but is largely practitioner driven. It focuses on the nurse's ability to uncover inequalities and advocate for change. And it does not require shared power with communities in the same structural way that CBCAR does. So ultimately, because Black maternal health disparities are deeply rooted in community context and lived experience, it's a model that will elevate community knowledge as well and make it essential. So the PICO question is asks whether a community engaged, culturally grounded approach to obstetric nursing, guided by community-based collaborative action research, can more effectively reduce maternal mortality and severe maternal morbidity among Black women when compared with standard obstetric care. In other words, does integrating the community's voice and collaborative action into nursing care improve maternal outcomes for Black women across the perinatal continuum? So, reviewing maternal mortality rates involves examining data on when, where, and how maternal deaths occur in order to understand the scope of the problem and detect inequalities and emerging risks. Also, identifying all the deaths where they're preventable and pinpointing modifiable contributing factors. And also, based on identifying preventable factors, and change can be a focus on implementing at the community level. So some examples of some policy are: the Health Resources and Services Administration has funded community-based doula programs under its Healthy Start initiative, with grant opportunities explicitly aimed at increasing the availability of doulas in high-risk communities to reduce disparities in maternal and infant outcomes. The Centers for Disease Control and Prevention publicly supports and funds state-based perinatal quality collaboratives. As of 2024, there are 36 active state-based PQCs, and these collaboratives bring together hospitals, community partners, public health agencies, and other stakeholders to implement evidence-based perinatal care practices. So thank you for your attention. I have several references here, and you can reach out to me if you have any further questions.